Hello, everyone. Welcome to another discussion on the pediatric masterclass. So, today we're going to be talking about prenatal testing for Down syndrome. So, we know that Down's is the most common chromosomal anomaly, and we as pediatricians do encounter a lot of kids with Down syndrome. And we know that Down's kids are associated with a lot of comorbidities. They have systemic illnesses, including heart disease, respiratory problems, endocrinopathies, and developmental delays. And with better understanding of the disease and with the advent of more and more screening tests available, a lot has changed over the past few years in terms of who needs to be screened, what are the screening tests available, how do you confirm a diagnosis, and what treatment options are available once you make an antenatal diagnosis of Down syndrome. So, this is an extremely important topic, especially for the postgraduate students. And without wasting any further time, we'll begin the discussion. So the overview of the discussion is going to be rationale of prenatal testing. So why are we interested in prenatally testing for Down syndrome? What are the screening and diagnostic tests available? And what are the advantages and disadvantages of each of these tests? So before we move into the discussion of the testing, let's see what conditions are screened prenatally. So mostly we are aiming for aneuploidies. Again, the commonest ones being trisomy 21, which is Down syndrome, trisomy 18, which is Edward, and trisomy 13, which is Patau syndrome. But depending on the prenatal tests being used, there are a lot of other conditions that also can be diagnosed prenatally, but these are the ones that we definitely want to emphasize on. So talking about prenatal testing for Down syndrome, the first question is, who should be offered this prenatal screening? Is it only the mothers who are at high risk of having fetuses with Down syndrome? Is it all pregnant women? Is it those who've had a previous pregnancy with Downs? So, the latest recommendations say, according to the American College of Obstetrics and Gynecology, which is ACOG, they recommend offering aneuploidy screening to all pregnant women in early pregnancy. Okay, so it's not only limited to those who are at a higher risk, say those who are elderly mothers or those who've had kids with Downs before. This screening should be offered to all pregnant women in early pregnancy, irrespective of the presence or the absence of risk factors. And second interesting point that they do recommend is that regardless of the maternal age, all pregnant women should have the option of choosing between a screening test versus a definitive diagnostic test. Okay, so we'll look at these details as we move ahead. Like in the prenatal screening, we have a set of tests available for screening, and we have a set amount of tests for confirmative diagnosis. So it is upon the discretion of the family whether they want to go ahead with the screening test or they want to straight away go ahead with a definitive diagnostic test. So why this recommendation really came up is because there are certain families who are very apprehensive in terms of whether or not their kid or their fetus has Down syndrome. Probably they've seen some family member with Downs, or they've had some experience before, and they do not want to take a chance, and they want to be 100% sure that that the kid is okay. So this is another recommendation that the ACOG gives. That's that it's the decision of the family whether they want to go ahead with only the screening or straight away go ahead with the definitive diagnostic tests. So why should we screen for Down syndrome? So Down syndrome is the most common chromosomal anomaly with an incidence of approximately 1 in 700 live births. Like I said, kids with Downs have a lot of associated systemic illnesses, and definitely that turns out to be a burden for the individual and the family both. And with the availability of accurate prenatal diagnostic testing, we really can offer this test of being able to diagnose and even confirm the presence of Downs in the fetus in the antenatal period. So that is why over the years a lot has changed in terms of screening of for Down syndrome in the antenatal period. So now if we stress on the prenatal testing for Down syndrome, we have two types of tests available. One is the screening test and one is the definitive test. So screening again can be divided into three types of tests. The first one is nuchal translucency, which is an ultrasound marker. The second one is serum markers in the mother's blood. And the third interesting and the recently developed test is the NIPT, which is the non-invasive prenatal testing. We'll be looking at each of these in detail in the further slides. Whereas if we go ahead with the definitive test, which is diagnostic, which is gold standard, which is required to confirm diagnosis, we have two. The first one is CVS or chorionic villous sampling, and the second one is known as amniocentesis. Okay, so let's begin first with the screening tests available. So the first one that we saw was nuchal translucency. So what exactly is nuchal translucency? Nuchal basically refers to the nape of the neck. Okay, so when looked at in the ultrasound, it appears the black shadow that we can see here represents the nuchal translucency. So what exactly is nuchal translucency? It's basically the subcutaneous fluid accumulation at the nape of the neck. So when the fetus is lying in the supine position, the most dependent part of the body is the nape of the neck. And that's where the fluid tends to accumulate. And when there is excess accumulation of fluid at the nape of the neck, that is what is seen as thickness or increased translucency on the ultrasound. So this is the first ultrasound abnormality that can be detected in the antenatal period as early as 11 to 13 weeks. Now, there's no one particular number that you can say that the nuchal translucency is abnormal because the measurements vary with age. Okay, they vary with the gestational age. So when you want to say that the nuchal translucency is increased, as per the definition, it means that when the thickness is more than the 95th percentile for that particular gestational age, then we say that the fetus has increased nuchal translucency. The reason for this again being that the thickness varies with age, so there's no one particular number that can be referred to as increased nuchal translucency. But definitely, thicker the nuchal translucency, there is more risk of chromosomal anomalies. So if we only look at nuchal translucency in the first trimester, it has a detection rate of about 65 to 70% to be able to diagnose Down syndrome antenatally. So this is one of the first uh, antenatal screening test that can be used as early as 11 to 13 weeks of gestation. So it's a first trimester screening test. Moving ahead, why is it that you can't only rely on nuchal translucency for the antenatal screening? That's because along with Down syndrome, there are a lot of other conditions as well where you might have increased nuchal translucency like other trisomies, so trisomy 13 and trisomy 18, Turner syndrome, Down syndrome, and even other conditions like congenital heart disease and skeletal disorders can have increased nuchal translucency. So only on the basis of increased NT on the ultrasound, you cannot be sure that this kid definitely has Down syndrome because it is seen in a lot of other conditions as well. So the next test that we have that again can be done in the first trimester is called the combined first trimester screening test. Why is it combined? It's basically a combination of your nuchal translucency and dual markers from the mother's blood. Okay, so the mother's blood is taken and we look for two markers. One is the beta HCG and the second one is PA-PPA. So pregnancy associated plasma protein A. So these are the two markers that we measure in the mother's blood along with the nuchal translucency, which is done between again 10 to 14 weeks of gestation. So once we have the NT and the dual marker values, there is a computed program wherein you put in information of the maternal age, the NT findings, and the hormone values, and the computed program will give you a risk score. Okay, so when the score is less than 1 in 250, it's called high risk. So, for example, let's make it easier to understand. If the risk score calculated by the computer program is say 1 in 100, that means there is a risk of having 1 in 100 fetuses with Down syndrome. Having said that, this is again a screening test, so your other 99 fetuses might just be normal and will not have Down syndrome. Whereas on the other hand, let's say you get a score of 1 in 1000. That means it's low risk and probably 1 in 1000 fetuses can have Down syndrome. So all of those tests that turn out to be falling into the category of high risk need to be confirmed by a confirmatory or diagnostic definitive testing, which is either a chorionic villus sampling or amniocentesis. So the combination of NT and dual markers has a detection rate of about 85 to 90%, which is better than using only nuchal translucency alone. Now we've seen the first trimester screening, let's go into the second trimester. So second trimester screening is done between 14 to 20 weeks of gestation. We have the triple marker test, wherein we measure 3 markers from the mother's blood, which is beta-HCG, unconjugated estriol, and alpha-fetoprotein. And this alone per se has a detection rate of about 70% to be able to diagnose or screen for Down syndrome antenatally. And along with that, another option is your quadruple marker. So you have these 3 along with another hormone, which is inhibin A, which has an 80% detection rate for Down syndrome. Now, another interesting screening test that can be used is called as integrated screening test. So it's called integrated because we are using findings from the first trimester along with the second trimester. So we look at the PA-PPA in the maternal serum from the first trimester, along with nuchal translucency again from the first trimester, and couple it along with the quadruple markers from the second trimester, and that together is called as integrated screening test, which has a detection rate of almost 95%. So it's really high. It's really accurate in being able to screen for Down syndrome. But on the other hand, it's a little difficult to do it in the real world scenario because you need to have repeated follow-ups with the mother with the first trimester screening, second trimester. So it's not a very widely used screening test, but definitely the detection rate is as high as 95%. So having discussed all of this, let's go into the next very interesting screening test, which is called as the NIPT, or the non-invasive prenatal test, or some people call it the non-invasive prenatal screen. Okay, so as the word non-invasive itself suggests, that you don't really have to stick a needle into the mother's womb. What is the principle of NIPT? So we're trying to detect fetal DNA in the mother's blood. So what happens when there's some amount of placental trophoblast apoptosis which happens? There is some amount of fetal blood which enters the maternal blood, and that fetal DNA is what we're trying to identify from the maternal serum and then test it. So if you look at this diagram here, the white basically is the fetal DNA and the blue is the maternal DNA. So in the mother's bloodstream, we do have some amount of fetal DNA, and that's what we're trying to isolate and then test for in the NIPT screening test. So this test can be done from 10 weeks onwards, and it has a very high detection rate of as high as 99%. So it's one of the best screening tests that can be used. But again, it's important to remember it is not a definitive diagnostic test. It is still a screening test, but it's got the highest detection rate as compared to all the other screening tests that we've discussed till now. Again, there's no test that comes without its fallacies and disadvantages. So one of the fallacies that there is a requirement of certain amount of fetal DNA that must be present in the maternal blood to be able to do the NIPT testing. Okay, so they say that a minimum of 4% of fetal cell-free DNA is needed in the mother's blood to be actually able to successfully do the NIPT test. Sometimes what happens when the amount of fetal DNA in the maternal blood is insufficient, the results can be inconclusive, and you might have to repeat the test. So it's possible that this might happen, but again, with more and more tests being available and more advancement, the amount of fetal DNA that's actually required to be able to do the NIPT is reducing day after day. So but they still recommend a minimum of 4%, so that might be a chance that the test might have to be repeated because of insufficient fetal DNA. So that is one drawback of this test. But yes, again, I will repeat saying that it has a detection rate of 99%, which is very good. Other than just for Down syndrome, other applications where you can use NIPT is to diagnose the fetal sex and sex chromosomal abnormalities. More intricate chromosomal disorders like microdeletions like in Dicot syndrome, monogenic disorders like hemophilia, sickle cell anemia. Rh genotype of the fetus, especially if the mother is Rh negative, if you want to rule out the possibility of isoimmunization in the fetus. And last but not the least, we are also looking forward to be able to do fetal whole genome sequencing from that fetal DNA that we're able to isolate from the mother's blood in the NIPT. So that's going to be a game changer the day we're able to do a whole genome sequence from just the fetal DNA in the antenatal period. So this is all that we've discussed about the screening tests. We've seen the types of screening tests available, the detection rate of each one of them, the advantages and the disadvantages. So once we've discussed the screening test, then let's move into the next topic, which is your definitive tests. So like we said, you have two options. One is chorionic villous sampling and the second one is amniocentesis. So what is CVS? So chorionic villus sampling is an invasive procedure which is usually done between 11 to 13 weeks of gestation. You never do a CVS less than 10 weeks because the rate of complications less than 10 weeks of gestation are very high. A CVS is always done transabdominally. Earlier, it also used to be done transvaginally, but the rate of complications with that procedure were very high. So, if you can look into this diagram, it's done along with ultrasound guidance. So, with the ultrasound probe, we try to locate the chorionic villi, and then a needle is inserted and a sample is collected. So, it's important to remember that when the sample is aspirated, the chorionic villus sample that we get has a mixture of both the fetal chorionic villi and the maternal blood. So once the sample is aspirated and we have it, we first need to separate the fetal villi from the maternal blood and the decidua, and then the sample is processed for its results. So this separation is an important procedure which should be done. Otherwise, we might have false or inconclusive results because you don't want to mix the fetal blood with the maternal blood. Okay, so this is what happens exactly or what is done in a CVS procedure. Whereas on the other hand, amniocentesis is usually done beyond 16 weeks of gestation, where about 15 to 20 ml of amniotic fluid is aspirated, and then those cells are cultured and multiplied. So what exactly we find in the amniotic fluid are the fetal cells which are shed off from the surface and the skin of the fetus, and that is why the diagnostic yield of amniocentesis sample is lesser than CVS, and that's the reason why these cells need to be cultured and multiplied so that we're able to get good results. Definitely amniocentesis is safer and easier to perform, and we do not prefer doing amniocentesis before 16 weeks. The reason being that we want to aspirate about 15 to 20 ml of amniotic fluid. So when done before 15 weeks, there might be a chance of anhydramnios or even increased risk of other complications like fetal loss, infections, etc. So 11 to 13 weeks, if you want to do a procedure, then it's chorionic villus sampling, and beyond 16 weeks, we can try for amniocentesis. So once we have the sample from either the CVS or the amniocentesis, the next option is what genetic test will you do on those samples. So you can either do a karyotype or a FISH. So this is what a karyotype looks like, and this is a karyotype of a fetus with Downs, where we can see 3 copies of the 21 chromosome, so trisomy 21. On the other hand, this is what a FISH picture looks like, with a healthy embryo having 2 copies of the chromosome 21, whereas an embryo with Down syndrome has 3 copies. So the karyotype report takes a little longer because cells need to be cultured, whereas the FISH is a faster procedure. Probably the results can be available within 48 to 72 hours. So depending on the time frame available and depending on the discretion of the parents and the geneticist, you can decide what test you want to go ahead with. Again, CVS and amniocentesis is a procedure that doesn't come without complications. So complications of these procedures could be the fetal loss, infection, bleeding, or RH isoimmunization. And that is why if you're planning to do any of these invasive tests in an RH negative mother, then always anti-D has to be administered before the procedure so that you can minimize the risk of RH isoimmunization. So this is about the definitive tests that are available for confirmation of diagnosis of Down syndrome in the prenatal period. One little small interesting topic that I would like to stress on is soft markers on ultrasound. So what do I mean when I say soft markers? So soft markers are basically abnormal findings that you see on the ultrasound, which indicate an increased risk of having a chromosomal anomaly, but in itself it has very little significance. So, what do I mean when I say soft markers on ultrasound? So, there are certain abnormal findings which are seen in fetuses with Down syndrome when you do an antenatal ultrasound. Okay, they are nuchal fold, so increased nuchal translucency and absent nasal bone. Okay, these are two commonest and two markers with the strongest association with Down syndrome. Okay, so if you have increased nuchal translucency and absent nasal bone or hypoplasia of the nasal bone, and that's the reason why if you see kids with Down syndrome, they have a flat nasal bridge because of underdeveloped or absent nasal bone. So if you have increased NT or absent nasal bone, they are very strong predictors of probably having a fetus with Down syndrome. But along with that, there are certain other markers on ultrasound which can be seen in fetuses with Down syndrome, can be seen in fetuses with other aneuploidies, or even seen in fetuses that are normal. So those findings or soft markers could either be an echogenic bowel, ventriculomegaly, short femur or humerus, intracardiac focus, or pilectasis. So what happens sometimes when these soft markers are diagnosed on the antenatal ultrasound, it creates a lot of apprehension in parents, when they have the ultrasound report in their hand and they're like, oh, this is abnormal, this is abnormal. Does that mean that my kid has Down syndrome? So then the dilemma is that how do you interpret these soft markers on ultrasound? So what is the importance of these markers? Number one, in isolation, they have no significance at all. These soft markers can be seen in other aneuploidies as well as even in a normal fetus. So, whenever we are looking at these soft markers, they have to be considered in association with other risk factors. Okay, so we look at the mother's age, we look at the findings from the other prenatal screening tests. Does the mother have a high risk of having a fetus with Down syndrome depending on her age, previous siblings, whether she and the husband has undergone a karyotype, etc., etc. So soft markers per se in isolation are not really given importance. They always have to be seen or considered in association with other risk factors. And definitely, when you have multiple markers positive on ultrasound, they are more predictive as compared to only having a single marker or single soft marker on ultrasound. So when you have like increased NT, absent nasal bone with an intracardiac focus, with pilectasis, with ventriculomegaly, etc., etc. So when you have more and more of these soft markers diagnosed on ultrasound, definitely they are more predictive of probably the fetus having Downs versus only having a single soft marker on ultrasound. So the last question that comes is, what do you do once you're sure that the kid or the fetus has Down syndrome, or you have diagnosed Down syndrome antenatally? So what do you do next? The first thing obviously depends on the weeks of gestation, but now because all the screening tests are done well in time, so there's enough amount of time for the parents to decide as to what they want to do as they move ahead in the pregnancy. So whether they want to go ahead with medical termination or whether they want to continue pregnancy is completely the decision of the family. And according to the guidelines, MTP can be done up to 20 weeks or up to 24 weeks in certain special situations. So, depending on the weeks of gestation that you do the test and you get the results, the decisions have to be taken accordingly. The next point is it is very important for us to provide all necessary information to the family as to what exactly is Down syndrome, what are the associated comorbidities, what other systemic illnesses can the child have as the kid grows, what is the prognosis. And a lot of times these families or these parents are connected with other groups that has or that is dealing with kids with Down syndrome, so that they can see for themselves and find out for themselves what exactly it is to be a parent of a child who has Down syndrome, and then it's their call as to whether they want to terminate the pregnancy or whether they want to go ahead and continue and have a child with Down syndrome. So it's very important for us to respect the family's decision no matter what they decide. And it's completely upon the discretion of the family as to which way they want to go. So that ends the discussion on prenatal diagnosis of Down syndrome. So we've discussed screening tests available, definitive tests, and another small discussion on soft markers. So I hope you found the video informative, and if you did like it, then please like, share, and subscribe. You can also leave your comments in the comment section below. You can also recommend other topics that you would want me to discuss. So thank you once again for watching the video. Have a nice day. Thank you.